This program is brought to you by Emory University.
So this morning I'm very pleased to introduce Dr. Leslee Shaw from our own division. Leslee, as you all know, is a professor of medicine here in the Division of Cardiology and is really internationally recognized for her work in a variety of areas, but a lot of it related to imaging and related to outcome studies. Leslee received her PhD from St. Louis University, has spent some time at Cedars and St. Louis University Duke and here on two occasions, and has been with us for several years now and is really, as I said, a national, international leader in this area. She has received numerous awards. Probably there's like 30 here on her CV, too many for me to go through. Most recently, the Red Dress Award, past president of the American Society of Nuclear Cardiology, and numerous other things. She serves on many of the major guidelines committee and organizing committees for the major activities in this area. And most recently was inducted to the Millie Pub Club here for her high-profile publications. She has over 300 publications on her CV in the original peer-reviewed area and numerous others in editorials, etc. And as I said, it's a real pleasure for us to have her here come today and talk to us about some insights from the Ischemia trial. Leslee?
Thanks, and good morning, everybody. Thanks for braving the wet weather today. So I thought I'd talk about the Ischemia trial for a couple reasons. One is that we're enrolling in it in several locations here at Emory, and I thought it would be interesting for me to tell you how we actually design the Ischemia trial rather than just talk about it and talk about the evidence, because there are a lot of nuances to trial design. So as all of you start to think about engaging in some other activities in designing your own trials, it might give you a little bit of insight into how larger trials are designed. So I thought it would be helpful for all of us. And we just go like that.
Oh, you can just see there.
So if you think about, Emory has had a long-standing history of working in the area of stable ischemic heart disease, and I'm going to, from here on, call it SID. And if you look at the available evidence in the clinical trials, there have been two focus, a primary aim and a secondary aim. The primary aims have looked at a long-term benefit in terms of risk reduction. Secondary aims have looked at softer endpoints in terms of symptom or ischemia reduction, and we're going to talk about each of those in sequential fashion in terms of the available evidence and what we've learned in terms of the available evidence in terms of surgical versus medical management in the area of stable ischemic heart disease. But before I do that, I thought I'd go into try to get you think conceptually about trial design. And there are three concepts that I'm going to talk about in terms of risk-based decision-making, thinking about the risk in the patient population as eligibility criteria, as necessary requirements for therapeutic risk reduction, and then thinking about high-risk imaging, since that's the majority of my research is in imaging, and what is the impact of higher-risk imaging or higher-risk imaging results or higher-risk ischemia in terms of the benefit for revascularization and improving outcomes. And then I am going to touch on some of the available but exploratory evidence that is available on therapeutic risk reduction. So everybody in this room knows about both of these trials. We participated in both of these trials, the COURAGE trial as well as in the Barre 2D trial. The COURAGE trial on the left was published now in 2007. It's a number of years old, but the evidence is still far-reaching and very impactful on the field of cardiovascular medicine. If you look at the COURAGE trial results, you can see that the p-value between those patients that were randomized to revascularization or revascularization plus medical therapy plus compared to medical therapy alone, that p-value was 0.6, not even close to being significant or trending in one different way or the other. The same for the type 2 diabetic population, the Barre 2D trial. Both stable ischemic heart disease trials, both having requisite criteria of eligibility of patients that have coronary disease, stable symptoms, or stable coronary disease, and some modicum of ischemia, and we'll get to that in just a moment. Oops, we went backwards. There have been some challenges with the available trials in terms of the COURAGE trials and the Barre 2D trials. And my biggest challenge with the trials is that the eligibility criteria for objective evidence of ischemia have been, in general, quite poor. If you look at the COURAGE trial, the objective evidence was ischemia was not only site interpreted, and we have a lot of evidence to show that sites in the setting of patient clinical criteria will overestimate the amount of ischemia. The eligibility criteria for COURAGE were really quite minimal. Apparently new resting SCT wave changes, 1 or more millimeters of exertional ST segment changes, or 1 ischemic imaging defect. We certainly know, since the COURAGE trial was designed in the late 90s, early 2000, that there is a modicum of ischemia which is prognostically insignificant. So having to get up to a better threshold of prognostically significant. So if you look at just in the COURAGE trial, 60% of those patients that were enrolled in COURAGE fit into the category of having none to minimal ischemia. So that's really, really a different animal if you think about a stable ischemic heart disease. It's really not, it's just a stable coronary disease population and not a stable ischemic heart disease population. So partway through the COURAGE trial, the executive committee decided to enroll patients who had angina and an 80% epicardial stenosis without any stress testing. That included another 10% of patients. So if we think about how people interpret both the COURAGE and the Barre 2D trial, in the setting of the fact that the vast majority of the patients had very, very minimal to no ischemia, it's really a different type of trial than the results would actually show. So let's move on just quickly and talk just about the secondary aims, because the secondary aims are very important. And you can see a real distinction between the primary aims, which is a long-term benefit, and the secondary aims, which would be a near-term benefit of symptom or ischemia reduction. And we all know that through 3 years, there was a demonstrable benefit in terms of patients becoming angina-free, whereas by the time 5 years of follow-up came, in terms of the benefit in terms of being angina-free in the revascularization arm, equilibrated such that by 5 years of follow-up, there was an equivalent amount of angina-free status in both of these patient populations, those to randomized revascularization as compared to medical therapy. And I know that this type of endpoint gets dissed a little bit, and it's certainly, I think, if we talk about patient-centered outcomes, this is an extremely important outcome, that patients in the medical therapy arm would be waiting quite a long time in order to have resolution of their symptoms as compared to a near-term benefit. Although I think on the opposite side of this, you can see that benefit is not that dramatic in terms of overall frequency, so we're still quite a benefit in terms of optimal medical therapy. But what about ischemia reduction? We actually had a sub-study that we did within the COURAGE trial, and all of you have seen this before, I know, but I just thought I'd introduce it just for those few people who don't know about it. This sub-study was powered to look at superiority in terms of ischemia reduction with revascularization. That's something that not many people, I think, realize when they talk about the sample size of this trial. We actually overpowered it. It was powered at around 220 patients. We enrolled well over 300 patients in order for us just to oversample that and to get a little bit more of a demonstrable difference. You can see that in terms of ischemia reduction, we decided on a threshold of 5% or more ischemic myocardium, a reduction of that as being prognostically significant. We used that as our endpoint. You can see that there was a demonstrable difference between patients that were randomized to revascularization as compared to optimal medical therapy alone. You can see this is quite significant. Illustrating this on this slide over here is a patient that had pre-treatment baseline. This is a total perfusion defect, and I'm going to explain to you just a little bit of the nuances of imaging, since I'm not sure this is always discussed. This is a quantitative program that looks at not, here you can see the circumferential, all this in black is ischemia. This is a heck of a lot of ischemia. We don't see this amount of ischemia very much. This patient was randomized to medical therapy. Most of you probably would have said this was a revascularization patient. And at the end of 12 months, had 2% or normalized the vast majority of ischemia. I like this TPD program because it not only gives me a circumferential profile of the extensiveness of ischemia, but it is a pixel-by-pixel quantification of the severity of the defect. So we use this program specifically because it was more sensitive to changes, not only in extent, but also in the severity of the defect. We thought, a priori thought, that the vast majority of our differences would be in the severity of ischemia, not necessarily in the extensiveness of ischemia. We haven't been able to actually ferret that out, but I still think that's a viable alternative. So there are lots of ways to quantify ischemia. I'm a particular fan of this because it actually is able to look at the severity of ischemia. And as we started to unfold our concepts and ideas about what went on in the COURAGE trial, we started to look at patients with higher risk ischemia. As all of you know, in the setting of acute coronary syndromes, there's a demonstrable benefit with an invasive approach. That invasive approach, obviously in the setting of acute coronary syndromes, those patients are decidedly higher risk. So as all of our investigative pool started to think about this, the concept started to evolve that maybe we just didn't enroll high enough risk patients. And so as we look at the moderate to severe ischemia, now this is not powered to look at differences by randomization, but you can actually see that the vast majority of patients who were randomized to revascularization had a significant reduction in ischemia. Interestingly enough, I would say not a trivial number of these patients on the medical therapy arm also had a reduction in ischemia. So it started us to think about, did we just not enroll enough people with higher risk ischemia? This paper came out last year from the Barre 2D trial that we put together. And Barre 2D, unfortunately, did not do a baseline imaging study. They just felt like the baseline, all that went on during the baseline exam was just too problematic in order to add a stress test. So this is a one-year pharmacologic stress myocardial perfusion SPEC study in about 1,500 patients. The exact same findings that we saw in COURAGE is that at 1 year, there's a much greater reduction in the amount of ischemia in the revascularization arm as compared to the medical therapy arm. Highly significant. And no difference in scarring, which is important to say that there was actually no silent MIs, especially in this diabetic population. So the percent scarred myocardium was similar. There's also some relevant findings, and all of you should be very familiar with these three trials in terms of stable ischemic heart disease. This is the FAME2 trial. I'm going to focus on the randomized portion of this. Patients this is FFR-guided PCI plus medical therapy as compared to medical therapy alone. Also, take note of the number of years of follow-up, 1, 2, 3, 4, 5. That was the a priori follow-up through 5 years. And so this is important as we start to look at the results. So in the primary outcome is something you all need to think about. All-cause death, which is a very tough endpoint. It's really basically the number of bodies standing, if you will, between the two. Myocardial infarction or urgent revascularization. The follow-up here now is only through 12 months. This trial was stopped prematurely by the DSMB. Anytime you think about clinical endpoints that occur, there are often different patterns. As somebody who's been on several DSMBs, there are often different patterns of events. Sometimes you get early events, perhaps in this case, early MIs, and then the later events can be a very different pattern. So stopping a trial early is a very risky venture. I know I've been on a number of DSMBs, and I've wanted to stop them, including the recently presented and published CORAL trial, which I wanted to stop early on. But you can actually see in this trial, if you look at the medical therapy arm in red, and you look at the hazard ratio, everybody in this room knows that the hazard ratio to look at the overall risk with PCI plus medical therapy, it's reduced by 68%, or 1 minus that hazard ratio. You can see that this risk is decidedly lower in the composite endpoint of all-cause death, myocardial infarction, or urgent revascularization. You say, well, what relevance does that have to the COURAGE and Barre 2D trial? The only endpoint of those three that was actually significant was urgent revascularization as a result of acute coronary syndromes, which really is the same pattern that you saw in COURAGE. It's the same pattern that you saw in Barre 2D, a near-term benefit of improvement in symptoms. In this case, improvement not only in symptoms, but improvement in symptom stability. So the only thing that we've seen heretofore in terms of a benefit with revascularization is a near-term benefit of improving symptoms in ischemia reduction. That's the strongest statement we have, and we still have not been able to put forth evidence that revascularization improves outcomes. Just to throw in some more timely evidence, this is observational data. It comes with it's all the fraught of observational evidence. This is a recent paper published in JACC, small registry from the Cleveland Clinic. 769 patients followed for quite a long time. Sizable number of deaths. This were propensity matching. It's a way of matching between the two populations. These patients were asymptomatic. So once again, this is a negative result, that p-value between those patients receiving medical therapy as compared to revascularization. The p-value is 0.53, suggesting that symptoms are a key for us to also think about in terms of identifying a patient population. This is just, once again, another piece and a more timely piece of that puzzle in terms of stable ischemic heart disease. I did want to point out these patients were enrolled with a variety of ischemia. You see this score called a summed difference score. This actually looks at the difference between a resting image and a stress image, which is the amount of ischemia. The sum difference score was on average 7, which is around 10% of the myocardium that's ischemic, just for those who are not imaging folks. And this really brought us to the stable ischemic heart disease guideline, which says to consider revascularization to improve symptoms and not to improve a patient's clinical outcomes. So that is an important piece of information, that the sole benefit that we've been able to accrue heretofore is for symptom improvement. But there's some key unanswered questions that I think really beg for us to explore even further. So should we actually look at a higher risk, higher amount of ischemia? Would that actually be a patient population to derive a benefit? And were the eligibility criteria insufficient? We do know there's a stark contrast between the SID evidence and the ACS evidence. And if you look at the available evidence, not really necessary to see all this in detail. The COURAGE trial, if we looked at, there was only 468 patients that had moderate to severe ischemia in COURAGE, very, very small amount. Similar, very small amount in Barre 2D. Both of these sample sizes were statistically underpowered and show no evidence of benefit with revascularization. So exploratory evidence, once again, is showing no benefit, but really in very small samples. Before we get into the concepts in terms of clinical, I'm going to spend the next few slides talking about trial design and how we actually think about trial design. So first of all, you need to understand the concept of risk reduction and how you actually match the intensity of the therapeutic intervention with the hazard for cardiovascular events. So there's a fundamentals of risk prediction. In this case, as the extent and severity of ischemia increase, there's a directly proportional relationship to risk, and I'll illustrate this on some slides in the next few slides. And the risk may be multiplicative. It's not additive. So if you go to mild, moderate, it's not necessarily 1 + 1 + 1. It can be quite accelerating, as I'll also show you on a slide in the next few slides. And that there is this concept of matching the intensity of therapeutic therapies to the coronary disease event risk. So that the therapeutic risk reduction, what you would expect, this is a general tenet, what you would expect, the therapeutic risk reduction is proportional to the underlying risk for cardiovascular events. So that means if I treat low-risk patients, if it's proportional, my benefit is going to be low. If I treat high-risk patients, my benefit is going to be higher. And it should be more intensive in terms of, this is a general tenet, it doesn't always work, and I'm going to show you one example in this case where that matching the intensity does not work, and if you can hold on to it for a little bit. So before we do that, we have to get through to some additional concepts. And if we're talking about risk-based testing, we're talking about doing this for risk-based management. A core of this approach is that we can identify the vulnerable patient and we can address that risk in the population, lowering that risk through changes in effective patient management. Importantly, if you think about an imaging modality, you think about how you work up a patient. The patient is sent for a diagnostic test, many patients, millions of patients every year. That imaging modality is interpreted. You, based upon the imaging results, make a change in management. That means that the imaging modality does not actually elicit a change in outcome, but it's the therapeutic intervention that makes a change in outcome. So an imaging modality does not have an improvement in outcome. So if we think about the ACS trials, we also now just confounded our relationship in terms of trial design. The ACS trials actually have a modality that diagnoses and then treats right immediately. But in this case, we have a diagnostic modality that doesn't alter patient management and doesn't affect outcomes, only insofar as treatment is initiated appropriately and effectively. So the test is in terms of designing a trial, is much more challenging because we have to make sure that whatever is on the modality is effectively diagnosed and recommendations are effectively followed out that we know could actually optimally position that patient for an improved outcome. So that challenges our relationship even further. And as the next few slides, I'm going to go through each of the imaging modalities that we included in the ischemia trial. And unfortunately, suffice it to say that we have very limited comparative evidence across each of these modalities. And so we are going to have to apply some risk-based decision-making in terms of understanding what is a comparable amount of ischemia, which is not an easy task. This paper is in Press and JACC Imaging. A number of people participated in this paper. It took me so long because there were a lot of people who were firmly against the fact that we could compare the amount of risk. The concept behind this is that we decided to choose a common level of risk and to go to each of the modalities and find out what that level of ischemia was. So, and it was different. It wasn't just 10% ischemia across all the modalities. It was different, a number of wall motion abnormalities, et cetera. So we used a risk-based testing approach to design the ischemia trial. And we started off with nuclear stress because, obviously, past president of FASNC, that was what I was most familiar with. It's also the area where there's a substantial body of evidence. We used it in COURAGE, we used it in Barre 2D. A lot of the investigators were very comfortable with this. But we wanted to expand it so the generalizability of the trial results would be expandable beyond echo and into MR, into other areas. And so we looked at the event rates associated with 10% ischemic myocardium because that was a consistent measurement of high-risk ischemia. And we identified a threshold of 4 to 6% per year death or myocardial infarction, and then we sought to look at the other modalities in terms of their available evidence. Now, in terms of nuclear imaging, if you look at the available evidence, there is a substantial body of evidence. There's also a number of quantitative scoring packages. We've talked about this, and this threshold of 10% ischemic myocardium is consistently been shown to be associated with moderate to severe ischemia over the last, since 1998, if you will, if you can believe that. It's been published for that long. This is the first paper that came out on death from myocardial infarction with moderate to severe ischemia. It used a semi-quantitative scoring package, which just basically looks at the segments, it looks at the severity of the defect in each of the segments. And you could see if we're looking at 4 to 6% death or infarction rates, this is actually an event rate so that all of these patients with moderate to severe ischemia would fit into that package. We've used much more sophisticated scoring systems right now over the last 15 years. And I showed this slide, even though it's a little bit not really relevant to here, I had to show it because this is Jenna Kay, paper that came out in JACC. She's a resident who worked with me, and she was lucky enough to help me and to write this paper through our collaborations, and it was lucky enough to get into JACC last June. So you can actually see this is rubidium PET imaging. We do a fair amount of that. This is cardiac death only, so you remember we were looking at death or myocardial infarction, somewhere around the 2% in this large cohort. So we can actually see that the nuclear literature is rather robust for the last 15 years. In this case, more recent evidence with PET, rubidium PET, showing ability to identify patients who have a lot of ischemia, 10% or more ischemic myocardium. Probably the biggest piece of evidence was this observational paper. Some 10,000 patients. This is from Cedars-Sinai. You can actually look at, there are two curves here. Those people in the room who may or may not be familiar with looking at log hazard ratios. They aren't my favorite to look at either. You do see that these patients in white, this is medical therapy. This is revascularization. This line between these two cross at around 10% ischemic myocardium, suggesting in terms of revascularization that there is an increased risk below that 10% with revascularization. But as we get more and more ischemia, and I can tell you, this is a little bit of a statistical artifact because there aren't very many people walking around with 50% of the myocardium that's ischemic. But the majority of the benefit in terms of revascularization were in patients that had 10% or more ischemia. As a matter of fact, the revascularization in patients with 10% or more ischemic myocardium, there was a halving of the events. So it was a 50% relative risk reduction as opposed to an adverse consequences for those patients with moderate to severe ischemia. So now if you think about the COURAGE trial, think about that. You may have actually layered on a hazard for revascularization for all of those patients with minimal ischemia on top of a benefit and got a null effect. It's extremely important to think about how these results impacted both COURAGE and Barre 2D. It's actually been shown as well. This is a paper out of the J-Axis registry. Nobody in the US actually knows this registry. As somebody who's been to visit these folks a couple of times. This is a very, very large Japanese registry showing the exact same findings in terms of patients with 10% ischemic myocardium. Those patients that had revascularization had a decidedly reduced cardiovascular event rate. It's important, smaller study, looking at different populations outside the US, not as rigorous criteria, but it's an important piece of the validation that perhaps there's a signal from the observational evidence that if we get higher risk ischemia, we may be able to elicit a benefit with revascularization. So let's look at echocardiography, because during the review process, we received a lot of criticism for going outside of nuclear. That is the strength of the evidence. All of these are illustration examples of moderate to severe ischemia. Echo doesn't show very well. These are all examples from the ischemia trial. So lots of evidence with echo as well, not as much as with nuclear, but in terms of there have been several registries which looked at moderate to severe ischemia, did get into that range when we used at least 3 segments with inducible wall motion. All of you know this who are in training and read stress echoes. This is probably the hardest imaging modality to look at ischemia, to look at inducible wall motion abnormalities, especially in the setting of resting wall motion abnormalities, and look at subtleties. So it's not an easy test to actually look at. And all of this evidence is really supportive of 3 segments as being comparable to 10% ischemic myocardium on nuclear. And we actually see in one paper published from the St. Luke's Roosevelt Registry looking at showing a benefit in terms of PCI plus or CABG, revascularization, as compared to medical therapy in patients with high-risk ischemia on stress echocardiography. So once again, another piece of the puzzle we could actually be identifying cohorts who might have a benefit. And so we put this together. We see very comparable endpoints with nuclear as well as with myocardial perfusion imaging, showing, you can see the sample sizes that we used. Whoa. Now I know why I stick to PCs. Stay away from max. And if you look at the literature here, this was some 64,000 patients were able to consistently get into that 4 to 6% event rate, similar with echocardiography in about 10,000 patients. MR was a different animal, if you will, because there's not a well-established body of evidence with MR. And here you can see a nice example of moderate to severe ischemia up on the right. This is from the ischemia trial, the MR imaging lab. The core laboratory is at Montreal Heart Institute. I should have said the echo core laboratory is at Mass General. The nuclear core laboratory is at Cedars-Sinai. And we had to cull together pieces of information. The available databases on prognosis are very small, and we're able to kind of cull out from the literature. Certainly, if you look somewhere similar to the results, but these are very small sample sizes when compared to the available literature, suggesting if you have 5 or more perfusion defects, you can get a high risk. You see it adds in their fixed defects, which we don't want. We want pure ischemia in there because that's viable. We think that that's the tissues that we can actually elicit a benefit with. And as you should realize that MR is capable of splitting the myocardium between subendocardial and epicardial, and so there's actually 32 segments in MR, so you can look at different layers of ischemia. There have been papers on 2 to 3 vessel perfusion abnormalities, oftentimes is associated with a high relative hazard for cardiovascular events. And we actually looked at a few other papers noting that on average 4 out of the 16 segments. So you can see how we had to go through this thought process of how you actually match the different risk in the population. And in some cases it wasn't straightforward, as in the case of MR, except that in the case of MR, it is a new technology, it is a growing technology, one that we do here a little bit more than we did a few years ago, and is the same is true across the country. So, and it's another piece of information that could enhance the generalizability of the trial results. So we put this package together. You see, based upon our guesstimation that we could hit that 4 to 6% death or infarction rate, you can see that we're able to, by risk-based approaches, we're able to quantify the amount of ischemia across each of the modalities and cull the literature, cull the evidence, and identify this. Now, this makes, all of you who have done clinical trials, this makes your enrollment a little bit more challenging, because we have different approaches. It would be nice and easy for me to say 10%, 10%, 10%. It might make it easier for you. But then we might have very different risks in the population. And this way, it actually allows everything to be equal in terms of eligibility. Now, we spent $55 million on Courage, 70 on Barre 2D. These are big mistakes. And so any future trials that we have going on, we have to be smarter about them, more novel designs in order for us to think about eligibility criteria. And one caveat to that is if we think about that, our proportional risk reduction based upon the risk in the population. We do know that the amount of ischemia, if you think about ischemic risk, it really is accentuated in the setting of LV dysfunction. This is a paper that we published a couple years ago. You can see here's the percent ischemic myocardium. This is the amount of resting perfusion abnormalities, or left ventricular function, if you will. It's another measure of the amount of scarred myocardium. We can see that if you have a normal resting study, your ischemic risk of coronary disease death or myocardial infarction is decidedly lower than if you have a lot of resting abnormalities. So ischemic risk is not just ischemic risk. It has to do also with the underlying extent of left ventricular function, dysfunction, I should say. And so the concept that we started to unfold and to think about, is there a limit to risk reduction? And did we learn anything from the Stitch trial? So that is another source of contemplation in terms of trial design. And we saw from the Stitch trial that there was actually no benefit in terms of a patient have ischemia. In the setting of LV dysfunction. As everybody recalls, the Stitch trial enrolled patients with an EF of less than 35%. In this paper, it has come out, and several other papers have come out showing no difference between patients who were ischemic and those that were not ischemic in terms of randomization, in terms of treatment, et cetera. So this is an important piece of the puzzle that maybe you do get to that threshold of too much scarring in the myocardium where you can't elicit a therapeutic benefit with revascularization. This was also a subsequent paper that we published a couple years ago in the European Journal. We did a follow-up, a longer length of follow-up, and we actually did some subset analysis in terms of that therapy. This is that same paper that was published from Cedars-Sinai in terms of looking at a benefit in terms of those patients that had LV dysfunction or less than 10% of the myocardium that was scarred as compared to those that didn't. This therapeutic benefit, and you can see these are hazard ratios. Here's a line of unity. Here's one. As these hazard ratios go under, that is when you get a therapeutic benefit with revascularization as compared to medical therapy. So you get this kind of thresholding effect in terms of 10% ischemic myocardium only in the setting when you have minimal scarring. So this is another thought in terms of eligibility criteria for the ischemia trial, that we can't just have all comers enrolled in that. So there are factors which influence the coronary disease event, but there are also factors that you reach a ceiling perhaps in terms of the amount of coronary disease events that you can't actually elicit therapeutic risk reduction. So our general tenet that we used to apply uniformly, you saw that paper that I initially quoted was from 1996. That was when I was at Duke, and when Rob Califf wrote that paper in terms of therapeutic risk reduction. But it appears that it's more complex than that there are thresholding of evidence that we do reach a ceiling in terms of therapeutic risk reduction. And this is why, in terms of the ischemia trial, so now we've given you eligibility criteria. We've given you some caveats to that eligibility criteria, and that is actually illustrated on the slide. So we have around 10% ischemic myocardium or its risk correlate with echo and or MR. Now we're looking only at a population with preserved LV function because we believe that is a population for whom we may elicit a benefit. And certainly one other thing that we're trying to do is to move back management before the cath lab. So the randomization actually occurs before the patient gets sent to a cath, as opposed to in Barre 2D and Courage, the patient was randomized after their anatomy was known. We feel that that was too much selection bias. There was too much of a drop-off after that. And so we're randomizing basically after the functional imaging assessment. But we also want to make sure that we don't have a patient here that has a left main. That would not be a good thing. So we actually have elicited and put into the trial design a blinded coronary CT angiogram. It makes the trial a little bit more complex, but certainly we have seen around 5 or 6% of the patients in this population that have left main stenosis, and we certainly don't want to randomize that patient to no cath. Is also, as well, there are people that have mild coronary disease and have a lot of ischemia. We also are seeing that. So both of those populations should be excluded, and that's why we have a blinded CT angiogram. 8,000 patients are randomized, 2 to 6 year follow-up. Anytime you see a range of follow-up like this is an event-driven trial. It's not a trial through 5 years. Anytime you see that range. So we're looking at a time-to-event approach and to cath versus no cath and treatment accordingly based upon the extent of ischemia and as well integration with FFR, et cetera. I'd like to just talk a little bit for the remainder of this, a couple ongoing activities that we're involved with. And this is actually the enrollment. This is the latest information from the ischemia trial. It's actually almost up to here now. This was from September. This is the available evidence, but I can say this in public. We actually are anticipating, we've got about 200 and some sites on board. We're anticipating getting to this enrollment date by somewhere in the middle of 2014. Just to let you know, Emory is actually coordinating all of the imaging activities within the ischemia trial. Abhi is helping me out extensively with this. We have an educational component to help the sites. We provide a lot of educational offerings for the sites, webinars, et cetera. We have 3 core labs, which we've talked about at Cedars, Mass General, as well as Montreal Heart and the Brigham and Women's Hospital. And we do offer a lot of these activities. We get one-on-one conference calls. We go over all non-eligible cases. We have lots of meetings that we put on and webinars and case-based. Most of it's case-based approaches to get people to identify moderate to severe ischemia. So this is a lot of our activities at Emory. And this is our data thus far. Those of you who are at the AHA's ischemia meeting, you've seen this data thus far. Interestingly enough, we're getting a fair amount of cases submitted with insufficient ischemia. We anticipated this, not as much as we see here, that sites are overcalling the amount of ischemia, and I think that's quite common in clinical trials, and that's one of the main reasons to have core labs. The image quality is quite good. If you look here, there's also other opportunities. This coloration, when I put it on the jump drive, it's hard to see. So you can actually see the differences. The amount of moderate to severe ischemia here is quite high for all of these modalities, and I think this could provide some nice opportunities for ancillary trial mechanisms. We're actually going to submit an ancillary trial application in February to look at the relationship between ischemia and non-obstructive atherosclerosis, in particular to look at identifying some true-false positives as well as to looking at the underlying burden of CT-defined non-obstructive atherosclerosis, which I think can be quite fascinating. And another piece of this component that I think in terms of understanding what Emory's role is in terms of imaging and how we interface with cath lab has to do with a project that we are just beginning that's in phase 1 development in terms of, it's called the Image-Guided registry. It's going to be a national registry. And I've been to CMS, I've been to every payer to try to get payment for this and to try to get help with this. We're actually going to interface all of the nuclear labs in the United States with a reporting system, and Ernie Garcia here at Emory has helped develop this. So we're going to seamlessly interface the nuclear labs with an automatic data registry, and we're going to track performance and metrics and radiation safety, and obviously because we've been to CMS, we're trying to get performance payments for this. But importantly for that, leave that aside for now. In the second phase of our Image-Guided registry, we are going to be interfacing Image-Guided with all of the national NCDR clinical registries, so that all of the cath PCI. So we'll be able to tell you the amount of ischemia and to have that available and have that fully integrated into the cath PCI, which, as all of you know, in terms of what's going on nationally in terms of elective PCI, understanding the amount of ischemia and being able to demonstrate that and effectively guide these two pieces of the equation from the diagnostic test to the invasive approaches can be very, very effective in terms of improving the care for these patient populations. So I think this is an important move forward. In the first 5 years of this is funded by industry. Hopefully we'll get to a point where this will be sustainable by, if a site gets performance payments, then they could share those with the registry. But I think this would really, really be helpful in terms of as we move forward. And so if you think about where our lessons that we've learned, I think I certainly have learned a lot of lessons that we need to be smarter in our trial design. We can't just emulate clinical practice. We've got to think about trial designs. We've got to think about whether or not we're enrolling patients that are sufficiently high risk in order for us to redesign clinically effective care. I mean, the goal of a clinical trial is to redesign and to have enhanced effectiveness. I think we've come a long way in terms of my understanding and all of our understanding of ischemia-guided management. I think the ischemia trial is a critical component for seeing how we can actually identify candidates for elective PCI. I had the opportunity to participate, I think Spencer you were at this, weren't you at this Joint Commission? There's been a lot of focus on PCI in terms of overuse, in particular of elective PCI. There was an AMA Joint Commission summit on overuse of procedures. This had to do with a lot of overuse, and PCI, elective PCI was one that was particularly targeted for a tremendous amount of overuse. In the vast majority of that overuse is notable in patients with low-risk ischemia. I think the ischemia trial fits very well in terms of the politics of overuse in terms of elective procedures, and I think they can really the ischemia trial can do a lot to support clinical indications for revascularization in this patient population. I think that's my last slide.
All right. Interlude here while I figure out how to do this. Open our chat window. Well, Leslie, thanks very much for a great talk. I'll start out, and for questions, again, remotely, use the chat box on your WebEx, and locally here, use the microphone. I have a couple of questions. I won't ask you why DCRI was represented as a big black box on the slide there. You can tell me about that later. But I guess I'm going to ask you sort of a mean question. So one of the things we hear, is from Gary Gibbons, who's head of Heart, Lung, and Blood, is, all right, I'm tired of incremental big trials. You guys beat things to death. You've shown. Why do more trials? And so, give us a sense of sort of what percent of, or, what percent, I guess, of the patients out there with stable coronary disease this is really going to impact, because we have a ton of these patients that are less than 10%, and we have a segment that are very severe. It seems like a lot of the data is really driven by those with 20, 25, 50% defect, and that's a small group. So I mean, give me a sense of that.
Yeah, I think that, Bob, that's a great point. And a couple of things in terms of, we go balancing with NHLBI in terms of pro-clinical trials, anti-clinical trials, and now we've gotten in a little bit to the anti-clinical trials. And unfortunately, big questions require a lot of money. Ischemia trial is $97 million. And Gary has said that he's not going to do a whole lot of multiple. He says, how many R1s could I fund for that? But it's also important to realize we need a balance of portfolio. And in order, I would also put the retort as how many R1s actually can answer questions that can deal with 20 or 30 million patients every year. And so that is part of that equation, that you need a balance of portfolios in terms of funding public. And in terms of where the advocacy issues are going, the advocacy issues are requiring more effectiveness evidence. You're not going to get those from R01s. So CMS, all the payers are telling you as clinicians, we're going to only fund where the evidence lies. And everything else, it's just say no. So if we need that evidence in order to drive practice, then we need to have more clinical trials. Anyway, in terms of the moderate to severe ischemia, somewhere in the neighborhood of 5 to 8% of patients will fit into this population. Now, it's really tough. It's tough when you think about clinical trial design, is if you lower it too much, if we bring down that amount of ischemia, and we talk about this every week in ischemia, if we go to a little bit less than 10%, we probably will go to around 7% of the myocardium that's ischemic. We don't want to go too low because we'll get into that really lower risk population, but we want to make it high enough. So there's ongoing discussions right now about lowering it just slightly more than mild. So we do get a little bit more than that, but it would not go to 5% of the myocardium that's ischemic. It won't ever go to that, but it will probably get lowered a little bit in order for us to get a larger pool of enrollees. But even in trial design, we always knew that one of the reasons, actually the ischemia trial is supposed to have 450 centers enrolling, and one of the reasons that we were going to have 450 centers is we knew that this population would be rather small. And I do think we are going to see that number lower quite a bit.
Questions? You've got a microphone.
Okay. So, Leslie, so I guess I want to ask you two questions. One of it is in the sort of category of stable ischemic heart disease, because those of us who are, using the NCDR and the Action Registry, there's a real challenge in describing a population or a patient as stable versus unstable. And it probably has to do with progression of coronary disease. We often meet patients that have 3 total occlusions in all vessels, and yet they're categorized as stable ischemic heart disease. Now, along the progression of disease, they've probably gone through the phase of progression and finally occlusion. So I guess my question to you is, do we really know who has stable ischemic heart disease and who may have subclinical acute coronary syndromes that might be better managed invasively?
It's funny. I've been having some discussions with Jagat Narula up from Sinai, and I actually think, even though I put forth this ischemia trial, I actually think we have one more evolution that we're going to see unfold in terms of targeting patients, and that has to do with looking at the underlying plaque composition in terms of guiding that therapeutic decision to go to revascularization, whether it be markers of soft plaque, if you will, whether it be looking at the amount of calcification. I don't know if we know. I think there's another evolution for us to truly target what you're saying in terms of identifying, the subclinical ACS patient who is the one, and I think that's operating a lot in the COURAGE trial and the Barre 2D trial. We have a progressive disease state. For years, I thought when I would interpret the COURAGE trial and the Barre 2D trial in my head, I came up to the thought that, is there anything that you all could do today that actually is going to make a difference 5 years from now, because it is a progressive disease state? I mean, isn't the only benefit is in terms of the episode of care, the near-term benefit? Isn't that what you're doing today for? And so I went through a whole evolution in thought, and I think that this is perhaps a good effort at looking at, does ischemia matter? But I do think we're probably going to take another evolution. And Jaggett and Valentin Fuster are trying to propose a trial to NHLBI to actually use CT characteristics to identify that. And so there's a lot of kind of thought on that lines that I think is more aligned with what you are actually talking about.
I think the beauty of the design you have is everyone pretty much is going to get a CT scan. So the idea of adding not just anatomic information to the hemodynamic paradigm, but also looking at plaque morphology, I don't know if it's prospectively specified or at least retrospectively looking at plaque morphology, looking at remodeling of vessels, looking at other things, the all shear stress that might, I think will be very
That's
important.
Jaggett's approach. I mean, that'd be, we are, our ancillary trial mechanism is hopefully to look for, to look at the plaque morphology, as you say, but not to do serial CTs. But go ahead. Oh.
Very nice, Leslie. That was great. But I think it's a theme that it becomes evident when you look at the development of the guidelines and the imaging group. And I congratulate the imaging group on all these things. But for everyone here, you need to realize that there's one imaging modality that is never considered, and that's angiography. That's been classified for political reasons as not imaging. And I call it political reasons. It's economic, it's a lot of things. It relates to this inappropriateness and you're talking about. But we should realize that that's a powerful tool. And I thought you might refer to the evidence from the COURAGE trial that showed that the degree of ischemia, measured as less than 5, 5 to 10, and more than 10, did not predict ultimate outcome, but the extent of angiographically documented coronary disease did. And we have a huge amount of evidence from the extent of coronary disease that this is also a powerful predictor. And so when you relate your question to what the impact is, I'm struck by the idea that very few patients, I think, with more than 10% ischemia escape the catheter, absent this trial. And patients with a little bit of ischemia commonly do. And is there not evidence in that group that could be gleaned from angiography that might help guide practice? Because there's one other thing missing from the ischemia-driven decision making. There's nothing about any of those three modalities that help us understand the potential for revascularization and the potential for the benefit, which is a fact found by invasive means, namely angiography and FFR. So, how do you relate that finding of angiography may be influencing this in addition to the amount of ischemia?
Yeah, and oftentimes that gets relegated to pre-specified endpoints of looking at, proximal LAD, looking at the number of vessels, and doing subset analysis in those patient populations. And in terms of the anatomy, one of the challenges with COURAGE is that the amount of ischemia was all site interpreted and was just absolutely abysmal. In terms of image quality, et cetera, and far from what you would think in terms of when we talk about ischemia. I'll give you an example of what we're seeing in the ischemia trial. Over the weekend, we had 14 studies submitted from one center, not in the United States. 14 centers, 14 studies that were submitted, 14 stress echoes. Not one of them. They were all submitted as site-interpreted moderate to severe ischemia. Not one of them was met eligibility criteria of moderate to severe ischemia. So we have a huge problem in terms of interpretive ability in the imaging world, and that's part of the reason for the registry. That's part of the answer, that I think that the anatomy is always going to be a strong prognosticator, and I think that in good hands, the ischemia can add on to that, and it's been shown to do that. And that's one of the reasons why the eligibility criteria have to be carefully designed, and not just the therapeutic portion of it, but the eligibility criteria, and that's why we focused on higher risk ischemia. I also think if you talk about FFR, I think one of the things in the ischemia trial is we didn't want to replicate the FAME trials. Those very nicely looked at anatomy-guided intervention with FFR. And certainly in ischemia, FFR is encouraged to be used in the ischemia trial. So I think one of the things I think we have to be careful from in terms of trial design is not one trial is not going to, even if it's $100 million, is not going to answer all of your questions regarding a certain patient population. I think the anatomy-guided trials, whether it be looking at plaque composition or whether it be using FFR, and in terms of that, that's one type of trial design. And that this is another type of trial design which really looked at the role of non-invasive stress imaging in order to guide therapeutic decision-making. It really emulates the clinical workup of patients outside of the cath lab in the decision-making pre-catheterization. So it's a different approach and different, not one I don't think necessarily is better. This definitely is a trial which falls very nicely after Courage and Barre 2D and some of the lessons that we've learned from those. It's not to negate what you just said.
Two quick questions. We'll do one from from Stan. Wants to know, should the imaging segment modalities have LID subsets versus 3 other segments? So
Yes,
this special.
Yes. We had a lot of discussion about whether or not we should say LAD alone. And I think actually the echo modalities are moving towards. I'll give you a little bit of tidbit to what happens in trial design. Is we moved all of, in terms of a protocol, we moved all of the imaging criteria to an appendix. And we just said eligibility criteria of moderate to of a certain ischemia, so that we can actually tweak the eligibility criteria anytime during the trial without doing an IRB amendment. Nobody's listening from the IRB, I hope. So that's another little kind of tidbit of things that you should think about, because you know, anytime I design something, you know, you think about it, and 2 years later I say, wow, you know, we're enrolling this, I wish I would have evolved it and morphed it a little bit more. And I actually think we talked about LAD, there was a concern that we would be, the data is not as substantial in terms of demonstrating that segment, that area, those wall motion segments or those perfusion abnormalities in the LAD territories, there's not a substantial body of evidence, so it was hard for us to justify that. But I do think the echo criteria are going to be looked at in terms of LAD plus 2 other segmental ischemic wall motion abnormalities. So I agree, the LAD. In terms of the nuclear labs, we are probably going to lower the criteria to about 7 or 8% ischemic myocardium, but I do think the LAD involvement is that evidence is not as substantial, but it's an area of ongoing discussion.
I think some of this has been addressed, but I was going to make the same point as Spencer did, which is that to take ischemia devoid of coronary anatomy is kind of difficult because we never do that. Because often if you get 10% or more, you have a coronary angiogram, and a left main with a 10% defect is very different connotation from a blocked right with a 10% defect, which you would probably do nothing about. So all these mega registries and outcomes really have to be then looked at in the, I guess, you know, modified based on the coronary anatomy. And you know, back in the days I was doing this stuff in the late 80s, early 90s, when all the CAS and European studies were coming out. We even wrote an editorial about this, but it seemed like the anatomy plus the ischemia was what was describing the high-risk cohort, and also the low-risk cohort where you could ignore ischemia. And then we sort of get into this area where you take each modality by itself. And then the second point I wanted to make, and perhaps I don't know whether ischemia is even planning to do this, is that what progresses coronary disease is inflammation and all of what you were saying about plaque and and it's really not that plaque that you're going to fix, it's some other plaque, right? That's going to burst and whatever. So, and we have all these many ways of detecting those things, which are systemic, biomarkers and things like that. And it's very powerful data to show that those things are predictive. And so you really want anatomy, you want ischemia, which we have up until now, before this trial, used as just a way of getting to the anatomy, and then your biomarker risk score, whatever, to see how risky you are in terms of plaque rupture and progression of disease.
Yeah, so I think it's important to realize that the ischemia trial, they all have to have angiographically defined disease. So that's important to realize. Now, whether or not it is truly ischemia-guided therapeutic intervention is really the question, as opposed to anatomically. So it's really similar to FAME2 in terms of its design. In terms of biomarkers, we do have a biomarker substudy. Jeff Berger out of NYU is leading that. The challenge with answering all of the questions is that really the available evidence that there is actually a biomarker that we can actually identify revascularization candidates who derive a therapeutic benefit is that evidence has not been identified. And so I think that is why there is an ongoing ancillary study to look at biomarkers. And but in terms of integrating that, it would also add complexity in terms of targeting those biomarkers for whom there might be a therapeutic benefit. I think would be challenging to add into the study design.
Okay, I want to thank you again, Leslie, for a great talk, and thank you all for all your great questions.
The preceding program is copyrighted by Emory University.